Okay, so we kind of agreed on some of the major reasons for using cytoreductive therapy, some of the controversies. So we've started cytoreductive therapy. When do we determine that we're just not controlling the disease as adequately as we want?
Right.
Rami?
Yeah, I think Ruben elegantly covered some of those elements. I think at the beginning, the key is really monitoring those patients frequently. I see sometimes that patients get started on treatment or phlebotomy, and their counts are checked like once every 2 or 3 months. I think at the beginning, that's inadequate. Like, those patients need to be monitored often at the beginning, maybe the blood counts every other week, bring them in every month till we get to that steady state or maintenance state. So I think that's a key. Obviously, what we look at, the blood counts, how well they are controlled, the symptoms for the patients, those are things we look at. And then obviously, once we start the cytoreductive therapy, what comes in the equation is also the toxicity or side effects of those medications, how well the patient is tolerating those treatments. And based on that, we decide. Usually, for example, with hydria, I think there is certain doses once you get to and you're not able to control the disease, that probably would be a signal that maybe to consider changing treatment. Like when you get into the 3-gram range of hydria to try to control patients with P. vera, I think the likelihood into running into side effects is going to be much higher. If the patients are developing cytopenias, with the treatment, I think that will be a sign to shift the treatment. And again, the symptom control, because there are really patients with P. vera, maybe a smaller subset, but that will have constitutional symptoms or itching that are not controlled with the first-line cytoreductive therapy that sometimes will need a second-line consideration because of that.
Okay. So we've been kind of talking around the CytoPV study and how it, directs our management, and we have this cutoff. But maybe I'll ask Jamil a slight twist on that question. So how strict do we have to be? I mean, if the patient is coming in monthly blood counts and is consistently requiring a phlebotomy, that they're spending some of their time above 45%. Is that a reason for considering cytoreductive therapy?
I mean, I think that there were data that, albeit retrospective, looking at the frequency of phlebotomy and outcome. And presumably, if your patient required more than 3 phlebotomies a year, then that correlates with a worse outcome. This is from Alvarez-Loran. But I think the one thing that we could control safely is the hematocrit. And I think the CytoPV study have demonstrated beyond doubt that keeping patients below 45% is associated with the 4-fold decrease in thrombotic events. And okay, so I may not be able to control disease progression, but I can certainly control the hematocrit. And granted, when you start to phlebotomize someone early on in the disease course, you probably have to do the CBCs a whole lot more frequently, perhaps once a week. I have people who have hematocrits of 68. Well, those people may need it twice a week until I am certain that they are optimized. And then afterwards, obviously, you kind of stretch the durations between CBC monitoring. And to your point, we have to be very cognizant of the fact that if someone is tethering around 45%, perhaps you want to maybe go for a lower cutoff so that you're not having instances whereby they are above 45%. So those are all the things that you have to think about.
So, and Rami, you brought up a very important point about if you go to 3 grams of hydroxyurea a day to control the disease, the ELN criteria say a patient should be treated with at least 2 grams a day for 3 months before you decide that somebody is not responding or having all the benefits of cytoreductive therapy. But so you have to be monitoring and titrating the dose. But at some point, you will decide that, as you said, you cannot push the dose anymore because of intolerance or you're just not getting the response.